Thank you, everyone, for joining us. We are so excited to bring you this topic. Good evening. I'm on the East Coast, so it's kind of evening in my time. We're 7 here, but welcome, everybody. My name is Ciara Styles. I'd like to thank you all for joining this informative webinar that is coming at an apt time in world news. I will be serving as your moderator this evening and I will introduce our lovely panelist. We could go to the next slide. Okay, well, first, let me just tell you about myself. I'm a child, adolescent, and adult psychiatrist for the telehealth company Talkiatry. I completed my undergrad and medical school training at the University of Florida. I completed both my residency and fellowship at the Medical University of South Carolina. So I'm still based in Charleston, South Carolina, and I'm rounding out my first year as an attending. I have a passion for treating children who've experienced trauma, and humanitarian crises are a large topic of interest for me. So that really inspired me to collaborate with these amazing panelists to learn more about all the aspects of treatment for migrant children. So let me tell you about them. Next. Okay, our first panelist is Dr. Balkozar Adam. She is a child and adolescent psychiatrist that serves as a professor emeritus of psychiatry at University of Missouri. She is a renowned clinician, researcher, educator, mentor, and advocate. She is a distinguished life fellow of the APA and ACAP. She served on the ACAP Executive Council and the Assembly Executive Committee. She has received the APA 2023 Agnes Purcell McGavin Award for Distinguished Career Achievement in Child and Adolescent Psychiatry, the 2019 Jean Spurlock Award on Diversity and Culture, and the ACAP Assembly Captures in the Rye Award. And the panelist after her is going to be Dr. Lisa Fortuna. She is a professor and chair of the Department of Psychiatry and Neurosciences at the University of California, Riverside School of Medicine. She is a bilingual and bicultural psychiatrist, child and adolescent psychiatrist, and health services researcher. Her career has focused on improving access to mental health services for traditionally underserved communities. She has over 100 publications and has been a principal investigator of national and international research funded by the NIH and PCORI. In 2022, she was the recipient of the Irving Phillips Award for Prevention by ACAP. She also received the Francis J. Bonner Award from Massachusetts General Hospital Department of Psychiatry and the Center for Diversity, which recognizes an individual who has overcome adversity and has made significant contributions to the field of mental health and the care of minority communities. In 2023 as well, she received the ACAP's Agnes Purcell McGavin Award for Prevention, which recognizes a child and adolescent psychiatrist who has made significant contributions to the prevention of mental disorders in children and adolescents and influenced the general well-being of young people. And our final panelist is going to be Dr. Shawn Sidhu. He is a professor of psychiatry at the University of California, San Diego, where he serves as training director for the Child and Adolescent Psychiatry Fellowship Program. Dr. Sidhu is a fellow of the APA and a distinguished fellow of ACAP. He has dedicated his clinical career to working with underserved and under-resourced communities in the Southwest, including Native American tribes and border immigrant communities. Dr. Sidhu initially helped to train approximately 1,500 healthcare providers in conducting asylum evaluations in border towns. He serves as a faculty member for the Asylum Medicine Training Initiative, which has reached 15,000 unique web page visitors from over 80 countries. Dr. Sidhu also serves as co-director for the Society of Asylum Medicine, has been a board member for Humanitarian Outreach for Migrant Emotional Health. He has served as an expert witness in federal immigration court and has testified to staff of the United States Senate Committee on Healthcare, Education, Labor, and Pensions on the issue of migrant youth and families. So we are so excited to see these panelists and hear their discussions tonight. We'll go to the next one, just talking about disclosures, and then we'll start with Dr. Adam.
Good evening. Thank you, Dr. Styles. My name is Balkozar Adam. I am child and adolescent psychiatrist, professor emeritus with the University of Missouri, Columbia. I want to welcome you all, and it is my pleasure to be here to share some of my experience here. I'm going to talk about culturally informed care of migration-related trauma in immigrant youth. My objectives for today is to learn about the effect of pre-migration, migration, and post-migration trauma on mental health of migrant youth, and to learn about evaluating and providing culturally informed care to migrant children and their families. Migrant youth can face lots of trauma during their journey. During the pre-migration period, they may experience violence, war, persecution, threats of death, torture, starvation, serious injuries, or they may witness the death or disappearance of family members. During the migration period, they may be forcibly separated from their caregiver and family member. They may spend months and years in refugee camps. They may be exhausted because of the travel, and now they have lots of fear about detention and imprisonment. During the post-resettlement and the post-migration period, they wrestle with acculturation stress. They worry about their family left behind. The family may have difficulty finding employment and safe housing. They may be discriminated against because of various reasons. And especially if the migration was not by their choice, it can become a precipitating factor for mental illness. They lack preparedness for the move. They have difficulty with their language and difficulty and diversity with their culture. They may have difficulty understanding the local system and adjusting to the new environment. All this adds to their distress. Some of the common consequences of trauma in this youth include PTSD, depression, anxiety, substance abuse, and suicidality. These youth are at high risk of emotional disturbance and mental health morbidities. This is especially true for those who are in the process of identity development while adapting to the new culture. There are several barriers that prevent them from seeking help. Language difficulty, dual stigma. They are not only culturally diverse, but they now have mental health problem that can lead to social isolation. They may have financial struggle and lack of insurance. They have limited resources, and now more than ever, they are afraid of the legal system. When the migrant and their family arrive, they have a wide spectrum of issues. The family need to find a paid job, transportation, housing. They may have delayed their preventive care in their home country. They may have pre-existing medical condition, and now they have severe mental distress. The youth have lots of needs, including need for special education, language service, vocational training, interpreter and translator to help facilitate the communication, therapy, social support from their cultural community and religious community. They may have other medical health problems that need to be addressed. So the process of evaluating and treating these traumatized migrant children and youth and their family can be complex and require special expertise and unique approaches. fortunately, we have tools that we can use to help them. The AACAP practice parameter for culture competence is one of them, and the DSM-5 revised outline for culture formation interview, and the online modules are helpful tools. The AACAP practice parameter was developed in 2013. Dr. Pumariega and his colleague developed this wonderful tool. It has 13 principles. Because of the time limitation, I will go over the majority of them at this time. Principle 1 discuss the barriers that can prevent culturally diverse children and their families from obtaining mental health services. This can be economic, geographic, insurance, cultural beliefs, and stigma. Studies show that non-Hispanic white families are twice as likely to seek mental health treatment for their children. Minorities are less likely to continue outpatient treatment or use other treatment options like therapy or case management. Often, the troubling behavior is identified by school or court and not by the parents. Principle 2 talk about the importance of language and the use of the language that the family are skilled at. As we know, psychiatry is language-based communication. So immigrants who aren't fluent in English may not be able to fully participate. That's why we need translator or interpreter. If we do not get the right translation, it may lead to misdiagnosis and adverse clinical outcome. Principle 4 talk about the importance of a clinician to be aware of his or her own cultural biases that might interfere with their clinical judgment and to work towards addressing these biases. Stereotype and prejudice both can lead to unequal care. We like to think that we are unbiased clinicians, but these are often veiled or subconscious thoughts that creep into our actions. If we use this stereotype of a specific group, it can affect our diagnosis and their treatment and the quality of care they are receiving. Principle 6 talks about the importance of evaluating and assessing the history of immigration-related losses or trauma, community trauma in the child and the family, and address this in treatment. The children and adolescents who are traumatized may experience behavior problem, aggression, sexual acting out behavior, substance use, depression, and anxiety, PTSD, or become suicidal. Principle 7 talk about how the clinician should evaluate and address in treatment the acculturation level, the presence of acculturation stress, and intergenerational acculturation family conflict in diverse children and their families. The child that comes from a different country must learn to balance tradition and culture at home with mainstream culture at school and outside community. If he is not able to master that, possible outcome can include marginalization, assimilation, separation, and negative identification. It's important to address the acculturation stress and the intergeneration conflict in treatment. Principle 8 discuss that the clinician should make special effort to include family member and key member of traditional extended family, like the grandparents or other elders, in the assessment treatment of the patient. Many of them comes from a collectivist culture. So they are willing to listen to their family and do whatever the family wish more than take care of their own needs and wishes. So involving the extended family may be the only effective option. However, do not sacrifice confidentiality. Discuss boundary and treatment parameter with the patient and their family from the beginning. Mental health may be a new concept for them. So when you get consent, make sure that you have a translation and make sure you give them extra time to make sure that they are agreeing to the treatment. Principle 11, clinicians should support parents to develop appropriate behavior management skills consonant with their culture, values, and beliefs. Studies showed that culturally adapted family intervention programs were superior to non-adaptive version. So advise parents about parenting practices that may be incongruent with Western culture, like corporal punishment. Principle 13, clinicians should identify ethnopharmacological factors like pharmacogenomic, dietary, and use of herbal cures that may influence the child's response to medication or their experience of side effects. We always need to consider the biological and genetic factor to combat health disparities because there are different patterns of medication metabolism and activity, and there is risk of side effects. Now I will move to the APA DSM culture formulation. DSM-4 introduced the outline for culture formulation as a way to study the effect of culture on the mental health. DSM-5 updated and revised the outline for culture formulation and added the culture formulation interview. The culture formulation interview is divided into 5 sections. The first one is culture identity of the individual. Is that person closely tied to his culture? Does he speak the language? Does he listen to the music? Does he attend social gathering? And then culture explanation of illness. From culture background, how this person see his illness. I have a patient telling me it's an envy of a relative that was not able to America that is causing him to have this problem. The third one is psychological stressor, culture feature of vulnerability and resilience. Stressors can be local, what he suffered during his experience with migration, or distance. Maybe his mother is alone in a war zone. Vulnerability. Maybe he has no social support. Maybe he is discriminated against. Resilience. Maybe he is having support from his family, from his community, or from his religion. The fourth one is culture feature of relationship between the individual and the clinician. This is to focus on the difference between the clinician and the patient in their culture. For example, the clinician might not have experienced discrimination. They have different language. They have different psychosocial status. So we need to keep that in mind because it can affect building trust and affect our treatment and evaluation of the patient. The fifth thing is we gather all this information and you have an overall culture assessment. Now, the culture formulation interview, it contains 3 components. The core interview, which is interview of the patient, and then informant interview, and then 12 supplementary modules. The interview of the patient consists of 16 open-ended questions. And it's supposed to help the patient get information, help the clinician get information about the patient culture and how he sees his problem. The first one is culture definition of the problem. What brings you here? What you tell people about what's happening to you? The second one is culture perception of cause, context of support. It asks question about what you think had caused you to have this problem. Maybe he might think there's black magic. Maybe he might think there's evil eyes. Maybe he think somebody else is doing that to hurt him. Context, what kind of stress in your life, and support. Is your family or your friend or your community supporting you? Then culture factor that affect self-coping and past help seeking. What have you done in the past? Maybe he prayed. Maybe he used some herbs. Maybe he also got help from a traditional healer. And then culture factor that affect current help seeking. What do you think you need now? We might think he needs antidepressant, but he might think he needs something very different. The informant interview asks similar question to people that are close to the patient, like family member, friends, and this can give us a better understanding of what's going on. For example, a patient can come and say, I hear my late grandfather telling me to do things. When you ask his family, they said, yes, this is happening and it's okay in our culture. And that will help him also feel supported by his family. There are 12 supplementary modules online that give you more in-depth information about that patient. One of them is about children, school-age children and adolescent, and one of them address immigrant and refugee. As you see, it asks question about background information. What is your country of origin? How long have you been living here? What's the pre-migration difficulty? What kind of migration difficulty you have? So to summarize, I want to end by sharing with you the refugee experience from the National Child Traumatic Stress Network. They are exposed to trauma. There are risk factors during the pre-flight. They are exposed to violence. They have disruption of their school. They have traumatic loss during the flight. Maybe they were in detention or refugee camp. They are displaced. They are separated from their caregiver. During the resettlement phase, they struggle with migration and loss, acculturation, and economic insecurity. However, they have also protective factor. They have individual factor. They made it here. They are resilient. Other did not make it. They have a family, may have family or caregiver that support them. They can go to school. They can have services, formal and informal services available for them. And they can have a community acceptance. The colors, yellow and the blue that I see here, remind me with the Ukraine flag. I would think that the Ukrainian refugee, when they come here and they see their flag displaced everywhere, they feel supported. With this is some references, and I want to thank you so much. And now it is my honor to pass the mic to my distinguished colleague, Dr. Lisa Fortuna. Thank you.
Okay. Good evening, everyone. So I think yep, I have access and I will. Okay, so I hope you see this in the right view. And I'll start presenting. So I'm going to be talking about what I'm calling children in the crossfire. And really, this is going to focus, my talk is going to talk briefly around a lot that we're seeing in our current environment in terms of immigration enforcement and the intersection or impact as it relates to trauma. And I really want to take us on a community level of what is the role of community. And I'll try to invite the idea that we are, as child psychiatrists, as child providers, of people interested in taking care of children and families, are part of that community. So again, I'm Dr. Lisa Fortuna, and I'm University of California, Riverside. Okay, so I will. So I just want to begin by framing us in this idea of social, cultural, and ecological factors that can impact on child mental health, because the things that I'm going to be talking about subsequently really relate to this idea of the social environment, and how that can have an impact on child mental health in general. And we're going to talk in particular about immigrant children. So, the research that I've done over a couple of decades now point to several things that are really social, cultural, and contextual. One is that a sense of belonging is a very important thing in child development, and I think we can all agree to that, in a sense of safety and community support and environment. And what my research has found in the past, looking at even epidemiological data, and even using nationally representative data, that individuals who experience low sense of belonging, that is something that is associated with suicidal ideation, associated. We did not look at causation in this study, but we definitely found a very strong association of, two or more the odds of experiencing significant serious thoughts of suicide when individuals feel like they do not belong. And what we found in some of these studies is that immigration status is also intersects with this, where individuals who have a low sense of belonging and who have a low sense of, or have stressors around citizenship, that those things can coalesce and increase mental health distress, and as well as suicidal ideation, as well as having an impact on family, family dynamics and family conflict, which also we have found on multiple studies is related to suicidal ideation. And I'm focusing on suicidal ideation here because we're really talking about, an important metric, right, of mental health in a population and an individual. And we also know that generational experiences, including intergenerational experiences of discrimination, we have also found in epidemiological studies related to depression. So we know that these social, cultural contexts are related to mental health and well-being. And when we're talking about children, I'm going to suggest that there's some particular things that we have to consider. Now, we all have been seeing the news around immigration enforcement. And so here at University of California, we had been, witnessing a lot of what was happening in the Los Angeles and Southern California region. It's happening all over the country, as you know. But you may have seen in the news around the escalation in Southern California and Los Angeles. And so we created a report that did some of what I am doing right now, is sort of, gathering what we know about the potential impact on a public health level of this type of implied and, in some instances, unfortunately, explicit violence that youth have experienced in regards to the immigration enforcement in cities, right? And the experiences of Los Angeles as being a point of departure for us to think about this. So, for example, so we wrote a special report, myself and some faculty and residents at University of California, Riverside, prepared this report, a special report on U.S. immigration policy and our understanding of its impact on the mental health of children and families. Our takeaway we can see in this box is that immigration policy in the United States is a source of chronic fear, and it's becoming increasingly so. Creates instability and trauma for millions of immigrants, with the expansion of enforcement mechanisms transforming daily life for families and children. And our invitation in this special report was that child psychiatry, those of us who take care of children cannot remain in the periphery of really thinking about how these heightened social political tensions and policies become policy determinants of health and mental health and unwellness. It is something that we have thought about in terms of family separations, how it has an impact on adult immigrants and deportations. But some of the things that we have been seeing in the news, and you may have seen in your regional areas as well, is that, there are also adolescents who have been taken by ICE and detained and deported. And this was a story from one of our local newspapers of Joanna, 17, who was nearly done with her sophomore year of high school when she, her mother, and her younger sister were detained by immigration agents, and they were deported a month later. And this was a very profiled case because people started to look at the impact on their peers, right? What is the impact on the other students? And what they found in qualitative interviews was that, this was very terrorizing for other of students in her high school, even for those that may not have known Joanna directly. They felt a sense of unsafeness. They felt that it could happen to any one of them. And a big theme came up in terms of really feeling a lot of uncertainty because it seemed like you may not even be safe of having encounters with ICE, even if you were born here, and sort of being swept up. So a lot of unsettlement, sense of unsettledness. And so what we really talked about in this report is that the pathway of immigration as a traumatic event is present. That deportation and detention experiences are emotional and psychologically highly potentially traumatizing on a child. And it could be the direct experience of detention and separation, real or threatened parental separation, deportation or detention, or the perceived threats to parents' life. They're being taken from one as a child, an ambiguous loss, and traumatic separations. And that we know that, through multiple studies, even for the last decades, that the child outcomes are disrupted emotional regulation, increased negative emotions, and externalizing symptoms are potential outcomes. Um, in the report, we talked a little bit about, how this might map on to DSM-5 TR criterion, right, in terms of the exposures of these events that are related to immigration enforcement. This is looking at it at a clinical level. And for a good part of the rest of my presentation in brief, I'll also talk about the sort of social environmental context of how we need to sort of ascertain and assess what are the needs of kids. But this is even at the clinical level. There's an exposure to trauma, witnessing, learning about the separations, learning about ICE raids, and potentially experiencing direct separation from a caregiver, and the exposure to violence that intersects with also the migration journeys or in the home country that people may already have had, as Dr. Adam had also presented very nicely about past historical traumas. This can relate to also intrusion symptoms where there's a lot of nightmares about separation or border violence, heightened fear during community or school raids, and avoidance, right? And I want to be careful, we can look at these things, and I want to point this out. If children are experiencing avoiding schools, clinics, or legal institutions for fear of deportation, we can look at that as a hypervigilance, thing that can maybe push towards a traumatic, sort of post-traumatic or traumatic related diagnosis. But there's also some adaptation there, right? Because people are really experiencing real and like just real threats, right, in those environments. So it can be seen also, we have to consider that it's adaptive to try to not be in those places that are unsafe. And also, there could be a lot of sort of negative cognitions about not being safe anywhere, right? Which is, we have to ascertain very carefully because there might be places that do become less safe, right? And so how do we sort of really dissect between diagnosis and what is actually adaptive? When we look at immigration-related adverse childhood experiences, I won't go through this too much detail for just protecting our time a little bit. But what we know is that these kinds of enforcements impact directly and indirectly through direct exposures and also through parental exposures and stress and trauma that passes down to the child's sense of anxiety. It can affect differently depending on developmental stage. You can imagine adolescents feeling some burdens around protecting family and others, young children really being fearful of separations. And we really have to therefore reframe immigration stress that's related to these types of policies as structural trauma. They're not individual pathology. Even as I, depicted, how it might map on to PTSD, we know that there are a lot of structural issues at hand. And so we have to have a trauma-informed, culturally responsive, and policy-aware care, and understand these whole understandings of that threat itself, like exposure to raids, checkpoints, immigration enforcements, can really in themselves have very significant outcomes that are negative. And then also they can there on, downstream relate to deprivation, barriers to healthcare, education, social services, economic exploitation, chronic poverty. So there are downstream effects as well. Now, I just want to shift towards the end part of my discussion is that there's cultural and contextual understandings that we have to have. And I saw in the chat that we were talking about sort of really understanding culture and context in regards to diagnosis. And we talked about the cultural formulation. But when we're talking about now the impact of policies and immigration enforcement threats, we saw that there's an opportunity for that youth may experience deprivation, right? And in not going to school or not having their parents engaged in their education as much because of the stress, because of like not going to programs and services. And what Dr. Gabriela Barajas Gonzalez found, a dear colleague of mine, was that, there's a cultural and contextual understanding that parents may still be very engaged in their child's education, still trying to support their children, but they're looking at it from looking at other helpers to help them. They may still avoid schools or settings where they feel are unsafe, but with support and social support and community engagement, they're still very interested in paying attention to their child's well-being, their education, their health, but they need the support, right? And they need the support of their own mental health. They can still be very highly engaged in children's learning. Their, engagement and culturally grounded, but it's often home-based or really looking at those culturally grounded sort of ways to support their children. Immigration enforcement does, reduce some form of engagement, especially out of home activities. We have to support their parents' physical and mental health, and the immigration threat has spillover effects impacting both immigrant and U.S. born Latina families or Latino or Latinx families. It does impact the community at whole that start feeling the threat and start experiencing a lot of anxiety. So, so I know we have limited time, so I just want to sort of say that, what we have been looking at a lot more is a social movement psychiatry, understanding that mental health is profoundly structural and social. We have to center experiences of communities and integrate mental health with social justice and structural changes. And, if you look at the APA report, we talk a little bit about different things that can happen in terms of psychoeducation supports through community health workers, promotoras, mutual aid networks, integration of psychiatry, pediatrics into legal advocacy and community holistic or, serving organizations, right? And that's places where child psychiatry can be. And, mutual aid, Mexican American, when we talk about mutual aid, which was one of the things on the in the table I just showed, that's been around for a long time. Mexican Americans have had mutual aid societies in the early 1900s. There's been sanctuary movements and all, Jewish organizations, Chinese family associations, really what it focuses on, and going back to my first slide, support, autonomy, dignity, and belonging. We know from a public health perspective that this is critical because mutual aid, and which literally means helping one another with resources, creates relationships, safety, and community post-migration, aligns with the principles of community psychiatry and effective support that is trauma responsive. And as psychiatrists, we know that social support is a protective factor for PTSD, even in extreme adversity. So down here in SoCal, we have things like Clínicas de Salud del Pueblo, Coachella Health Clinic, where we do have promotoras and community health workers that are working with organizations in Riverside County, where I am. There's been groups created around safe spaces for Latinos and immigrants facing increased enforcement to provide that social support. And that is making a difference, right? And helping parents, for example, to find places of support and resilience for themselves and for their children. And these are just sort of some pictures of even through COVID and now with the immigration stressors, these are, organizations are coming together, including when all of these kind of drastic events like COVID or immigration enforcement sort of impacting on people's even food access, right? And creating communities where food insecurity can be addressed. So my last part of my talk is really we have to support the supporters. What we are also finding is that mentors and volunteers working with migrant youth are experiencing emotional exhaustion. And they all recommend organizational supports, places where peers can reflect and get structured supervision around mental health things that come up for themselves and for the communities that they're serving. And we see this across many, many sort of studies, human rights defenders experiencing burnout, really wanting to have like some support in schools, teachers and counselors that become de facto mental health providers. They report compassion fatigue. COVID-19 showed increased stress and anxiety, and teachers of the helpers get distressed. So what are we to do as child and adolescent psychiatrists? One, I think I've talked about reframe symptoms and understand that some of them are adaptive and survival responses, not psychopathology. We need to apply trauma-informed principles as well as think about what we can do at the individual and organizational levels. We have to integrate historical trauma and current social political context and understand what are the factors that are impacting on our patients' mental health. Partner with community organizations, faith-based, build trust, extend reach, promote culturally grounded care, and support the workforce, right, around that secondary trauma and compassion fatigue, and engage in policy advocacy to reduce structural drivers of threat and deprivation. And I'll just end with a little quote from Father Gregory Bowl. Love is not weakness, but the strongest force for healing, especially in divisive times. And we don't always talk about love in psychiatry, but this is back about feeling like you belong, feeling like people care about you, can go a long way. And we can do that together with community. So I thank you. And I am going to pass it to Dr. Shawn Sidhu, my dear colleague.
Thank you so much. And let me share my slides here. I'm going to share a few and then I might kind of exit out a little bit and then skip ahead just to get everyone out of here on time. But I do want to say I'm very honored to present here today, and particularly with these two co-presenters, Dr. Fortuna, Dr. Adam, who are really luminaries and to me, they're mentors and heroes and people who walk the walk. So to share this space with them is huge honor. Um, so I give thanks to the Kumeyaay Nation. This is our local sort of tribal nation on whose land everything around here is built, and we hope to continue working to build trust with this community. So I don't know how many of you feel like this, but I've certainly felt this way, and I think this is really just to acknowledge that we're living in dark times. We're living in very, very dark times. And I think everybody who does this work has a little bit of a bright light inside of them, right? And you're trying to carry it. And sometimes it feels a little bit like, oh my goodness, there's so much darkness. Can my light cut through it all? I've had that feeling a little bit, just this feeling of like, is there anybody out there? Is there anybody listening? Like, what can I do? And every time you feel like maybe there's a win, there's like two or three losses. So, and these are things that have been said by public officials about like an entire race of people, which is clearly not true. But I'm just going to say it because they're actual quotes. They're murderers, they're rapists, they're drug dealers, they're bloodthirsty criminals, they're eating the dogs, they're eating the cats. I mean, these are things said by our folks in power right now. So the question is, what's this little girl thinking when she hears this and she's in your clinic? And I mean, so we're seeing basically widespread dehumanization of an entire race of people, which really post World War II was supposed to be everything that we as a nation were against. And the dehumanization is what has justified probably the worst chapters in American history because it allows you to do what's otherwise considered unethical to an entire group of people. And rhetoric matters, and I think we've already touched on this, but what's a kid who's lived through a civil war, who's fleeing armed conflict, or a kid who's growing up in the United States and has been around community violence going to think when they're seeing this no ID badge, mask, covering the face, weapons on openly on display, it's going to have a huge impact, right? And so, but I would just leave us with this, that in our darkest moments, the light shines brightest. And you can see that because there's total darkness, it is a pretty bright light, but we have to lean on each other. And if there's just a few lights, couple extra lights, and Your friend is a light. One of us can try to be a light for you. You guys can be lights for us and for each other. Then all of a sudden you don't feel like you're in this pitch black space where there's no hope. So I kind of wanted to set the frame a little bit that way. I'm going to move through very quickly here to some future elements in the presentation just to make sure we get through it with enough time. Okay, let's see here. And this is actually an inspiring story of a young man who was in healthcare and was stuck in a refugee camp and became the de facto um, doctor of the camp. And so this is a story, I think it was released by the New York Times. So a little bit of hope in there with all of this other stuff that we're talking about. But what can you do in your clinic? This is supposed to be sort of a practical 15 minutes of like, what can you do clinically and what can you do in terms of, other sorts of stuff. Both Dr. Fortuna and Dr. Adam did a great job talking about sort of other elements of this care, including like sort of cultural sensitivity and things like that. So I skipped through some of those portions. But in terms of just, very practical, like, should I ask about immigration status? And there have been a lot of different ways that people have thought about this, and there's not just one way to think about it, but it's sort of like, right now there's clearly a fear of deportation, which we've sort of touched upon. Um, and people right now may be avoiding healthcare facilities. They may be sort of suspicious. Um, and so I think we want to be sensitive around things like social security numbers for mixed status families and things of that nature. And so ultimately, we're not mandated to report anyone's legal status as healthcare workers. So just know that this is like, this is not sort of like a HIPAA thing. Like we're protected under HIPAA. We don't have to ask. If we do ask, we don't have to document anything in terms of legal status for our families. And someone, in terms of putting this type of information in your electronic health record, we know that any of our records can be subpoenaed at any time. So I try to chart with the idea that someone may one day read this note, and only kind of like inquire about these sorts of things if they naturally come up in terms of linking families to services. So just so you know, in terms of documentation, you don't have to document it, and just try to make sure you're comfortable with anything with in your note being released to a court. So what else can we do? We can engage with these communities, try to help be a part of building bridges, ask about their needs. So providing education is huge. Letting them know that there is confidentiality in terms of what they say to you and that you cannot release any of this without a court order or without a judge sort of asking for it. We can try to avoid asking for social security numbers because of the reason that it could jeopardize the patient and/or it could cause them to not trust us as much. Dr. Fortuna already talked about promotoras, but we can actually use community health workers who are from the community, who speak the language, who know the community well, as a way of engaging with that community and building trust. And so this is the Know Your Rights card. Some of you guys have probably seen these. And I've actually heard another speaker say that she encourages her patients not to pull them out anytime there's a uh, sort of an interaction with law enforcement, because that this particular speaker felt that actually makes a bigger sort of like red flag for the patient. But I think these cards are helpful. Sorry, I have a little cold. Just in terms of letting the families know what their rights are, and they should be aware. So do not open the door if an immigration agent is knocking on the door. Do not answer any questions from an immigration agent. If they try to talk to you, you have the right to remain silent. Don't say anything or sign anything without first speaking to a lawyer. You have the right to speak with a lawyer. If you're outside the home, ask the agent if you're free to leave. And if they say yes, leave calmly. Give this card to the agent. Now that's where, like, at this point I've heard some people say, don't give the card to the agent. So at the very least, we want to be able to educate folks about what the contents of the card are. And then there's a number you can call. And then there's some little like sort of sample paragraphs that people can use when they're speaking with immigration folks, like, I do not wish to speak with you, answer any of your questions, or sign or hand any documents to you based on my Fifth Amendment rights. I do not give you permission to enter my home based on my Fourth Amendment rights under the United States Constitution unless you have a warrant signed by a judge. I do not give you permission to search any of my belongings. I choose to exercise my constitutional rights. So it's good for people just to be able to review these sorts of things, even if they're not going to pull the card out. And in terms of our clinical programming, I think Dr. Adam and Fortuna talked a lot about why it's so important to work clinically with these communities. It's an advantage if we're building a clinical program for it to be in an area where high concentrations of newcomers are living, or you could say any kind of like immigrant communities, which improves transparency, trust, visibility, and ultimately we can. For some cultures, like Dr. Adam was saying, that there may be some decreased help seeking in certain communities for a multitude of reasons, many barriers to care. We can also try integrated care models. If people feel more comfortable coming into a primary care office and then having a psychiatrist or a therapist or a warm handoff present, that can kind of like decrease some of the barriers, not all of the barriers. Okay, so what to do if ICE comes into your clinical setting? A conversation we never thought we would be having, and I'm hoping that we get some policy statements about this pretty soon through our major organizations. But what you're supposed to do, and I would talk to your healthcare sort of organization about this. Stay calm and professional. It doesn't help if we're escalating things. Do not physically interfere. So we don't want people wrestling with ICE agents. I mean, we just saw what happened, recently. So ICE is willing to use pretty lethal force if necessary. Um, Verify warrants. So don't allow entry to private areas like patient rooms. I mean, they may need a badge to get in without a valid judicial warrant. If you feel like, I don't know what a valid warrant looks like, you contact your clinic directors and you have them become a part of that process. You can also sort of just say, I don't know what to do here, and I can't let you back because I don't know what the policy is. Contact the authorities. So hospital security, your legal department, or a designated response team. If you don't have a designated response, it's probably a good idea to talk to your clinic directors about. Maybe we should have a protocol in place just to make sure that we know what to do. Protecting patients, so we do not disclose patient information is confidential without a subpoena from a judge. And we ensure medical care is uninterrupted. So that's the most important thing. We don't want some sort of harm to come to a patient because this thing is happening, right? Like we have to treat patients. That's our number one job as doctors. Our job is not to try to get involved in, what ICE wants to do in the moment. We have to focus on our patients. So continue your patient care. Know your rights. You don't have to answer any questions or provide any documents without a subpoena. So if someone asks you for a chart or a medical record or a list of social security numbers, you don't have to do that. Politely state you're not authorized and you must follow protocol. Document everything, record agent names, badge numbers, time, date, warrants, actions taken. If agents are physically imposed, try to record it with your phone. And advocate for patients, provide high quality health care, and that always takes precedence over anything else. Okay. Um, so other ways to get involved. You can do asylum evaluations. And this is just a little bit of background on asylum. It's anybody who's been persecuted or discriminated against or experienced torture on the basis of their race, religion, political nationality, opinion, or social group. And it may sound daunting, but if you're a psychiatrist, asylum evaluation is easy because it's really takes a lot of the skills that you already have. You know how to do an H&P, you know the DSM-5, and it's just there's a few tweaks that you have to do. You just do one or two, and you'll feel pretty good about it. And this is just kind of like five W's in terms of any healthcare provider can do this. You can do it, at the detention center and the community, and you can do it at a time that works for you. But I think this is really the main take home is that 10% of people get asylum without an attorney, and most of them don't have attorneys. 30% would get asylum if they have an attorney, but 90% are able to get asylum if they have both an attorney and a forensic medical affidavit, which is the fancy name for your H&P. So they make a huge difference, a huge, huge difference. There's a place called the Asylum Medicine Training Initiative where you can take a 5 to 7 hour online course if you want to do a full. I never took any kind of course like this, but if you feel like you want like the most comprehensive training possible, you can just look up Asylum Medicine Training Initiative and it'll take you to a 7 hour course, 5 to 7 hour course. At that point, you're really ready to go, and you would just need to maybe work with a mentor on one case. Um, Okay. So the way that you get involved in asylum evaluations is if there are any medical organizations already doing the work, you're pretty good. If you're the only one doing this work in your area, you could just Google immigration attorney and make those connections. If you don't have like people in your area who are doing this work, there are these three organizations, Physicians for Human Rights, Mount Sinai Human Rights Program, and Humanitarian Outreach for Migrant Emotional Health. All three of these offer virtual asylum evaluation. So you could literally be anywhere in the country and you could be evaluating people, even if you don't have anything in your local community. So this is just looking at those organizations. And then you can volunteer if you're kind of thinking I'm sort of just I don't want to do any more medical work. You can also just spend time volunteering. So there's a lot of, I know Lisa has a bunch of organizations she's worked with in Southern California. Here locally, we have Refugee Health Alliance who does like amazing work across the border um, in migrant and refugee camps. And we actually got to go into the camps through an ACAP grant to do a joint training and a volunteering effort. And this is what some of the migrant camps in Tijuana look like. This is our makeshift pharmacy, which we carry on our backs in a backpack. Um, and some people who are Mexican child psychiatrists who are also helping us out. Casa Alitas is an organization in Arizona that helps to reunify families once they've been separated. And No More Deaths is an organization in Arizona that helps to set up aid stations where people pass away because it's too hot and the conditions are too brutal in a lot of these places where and it's also very cold and there's big rivers that you have to cross. So they set up help stations that help people to survive. And then advocacy is another piece. So the premise of this is that these kids and families they have a very, very direct repercussion for speaking out, and they really can't speak out for themselves. So we really need to speak out on behalf of this community because they have it's too much, the repercussions for them. So you can get ACAP advocacy and collaboration grants that give you about $4,000 to do a small advocacy project. You can write policy statements, not just with ACAP and APA, but even your local branches and chapters. Um, we have a new ACAP task force on children, families, and immigration, which is sort of a continuation of a former resource group. I know Lisa's doing a lot of work on this at the APA. You can write op-eds for your local newspapers or for these ACAP, and you don't have to put a bunch of references and stuff. It really can just be about kind of your thoughts on a particular topic. I just did a PBS interview. I mean, I think people are really hungry for experts to come and talk about the data on everything that's going on right now. And you also can meet with your representatives. One thing I would definitely recommend is signing up for the ACAP and APA action alerts, legislative action alerts. They'll send you an email when there's something going on, like don't cut Medicaid. And then you just type it, it's all pre-templated for you. You just have to type in who your Congress people are, and it just sends it for you. It's like the easiest thing in the world. Volunteering, we talked about fundraising. So I was saying that you can get these $4,000 grants. It doesn't sound like a lot of money, but $1,500 paid for about 70 mental health evaluations in Mexico because of how far the dollar travels in Mexico. So a little bit of money you raise can really go a long way. Um, and yes, so I think with that we should probably stop. But I did want to say, um, maybe to the last slide here, that this is a girl from Syria who did make it to Germany. And I did want to say that, you know, people do get better. A lot of these kids and families that I've worked with who get treatment, get evaluations, get the services they need, they get better. And that's one of the most amazing things to see. But if we don't have the opportunity to work with them, then we don't necessarily see that side of it. So sorry I went over, and that's all that I've got. Thank you.
Well, thank you to all of our lovely panelists. And we do have a little bit of time saved at the end. We're going to finish at 8:15 and get everyone out. But we want to give a little bit of time to ask questions and provide some answers. So we do have a question and answer option if you don't feel comfortable sharing your question out loud. I also have some prepared questions that I can kind of start with, and then I'll just kind of jump in whenever we can. Um, so, I mean, thank you all for your presentations. Honestly, they were really informative, and um, it's just so helpful to know how we can get involved, but also just some of the different impacts that do happen on our patients. Um, and I think one of the questions that I have is kind of what do you think may be the best way to kind of manage how our patients are feeling about removal of their family members? Like not necessarily them being directly affected, but indirectly affected. And what would you consider to be some of the best practices? Dr. Sidhu, you can start if you want.
Yeah, well, it's horrible. I mean, it's a pretty horrible kind of conversation to have with the family, knowing that they're not alone. And then one thing that we didn't get into, just I think because of time, is that you can write letters. I've written letters for a number of kids and family contexts. So even if you're a treating provider, so it's not a forensic evaluation because you're the treatment provider, you can say, I've been treating Susie. You know, Susie's dad is currently going to court and is having deportation proceedings. Since Susie's dad has been getting deportation proceedings involved in that, her appetite's gone down, her depression has increased. Susie was born in the United States. Susie's a U.S. citizen. This is impacting her care. Her teachers are reporting that her classroom attendance has gone down. So you can write this letter, and then if there are other people, coaches, pastors, other people who can write such letters and submit them to court, it's not every immigration judge who's, approving zero cases, in terms of like there is still some variability in immigration court, and some people may be a little more sympathetic. Um, but I think that's great. Just knowing that they're not alone, knowing that there's someone in authority who listens to them and hears them and validates them and is willing to write a letter for them is huge. But I would want to hear what my colleagues have to say about it.
Yeah, I mean, I would echo what Dr. Sidhu is saying. What I would add to that is, he's mentioning that, we can write and on behalf and to sort of help our patients. He mentions about other clergy and things like that. And that's another way where I think it's really important for us to have relationships with these other groups that might be able to sort of really, and encourage and validate. Like, I mean, the first thing is validate and hear and listen, right? And understand what the families are going through. And it's real, right? And then trying to sort of identify, they have resources, they have networks of how they might be able to work with those people to do things like letters. But then also, if it gets really challenging and there's a real concern about that, there's a real threat that someone might be deported in a family and it might leave children without parents, then what we're supporting a lot of clinics to do is to talk to families about a plan. Like, what if, my sister who is undocumented is deported? What are our plans for, the, her children, right? And do we and there's actually documentation of that legally of the wishes of if I were to be left, if I should be taken, who would my children go with, right? Does my child have special needs? How do I make sure that they continue with that care? Like actually making a documentation of wishes if we are to be separated. And that seems very sad. And it is tough, right? But it is a way for families to prepare, right? So they're not kind of stuck where now the child is, not knowing where they're going to be. And they know that they're going to have their aunts or, do you know what I mean? So actually making some plans like that. And it validates the fear too. And it opens up the conversation about what people are contending with.
I would like to say it also that it's important that we don't give them false hope
Mhm.
because the kids are smart and they know. So I agree with Dr. Fortuna and Dr. Sadhu. All these are very important. And I also want to say connecting them to community resources so they will not feel alone, whether culture, whether religious, whatever they are. And the school also play an important part in their life.
Yes, thank you all for those answers. And I'm looking at our question and answer chat. And so I feel like Dr. Fortuna, you kind of addressed that first one, which was really helpful. One of the next questions is, what are some of the biggest pitfalls that you see in diagnosing PTSD or anxiety in our asylum-seeking children across cultures? How do we guard against the misdiagnosis?
Mhm. Do you want to take that, Dr. Sidhu, first? And
Sure. I mean, I think normalizing and validating that, anybody who's gone through this would probably have symptoms. And letting people know that their diagnosis is not a label. It's not a lifelong sentence. It's not even really a part of who they are. It's simply a way for us to be able to communicate with each other as healthcare providers about what's going on. And more importantly, if we're doing some of these letters and forensic stuff, it's to communicate to the court what the impact of the trauma has been on them. But and this is whether we're working with immigrant youth or non-immigrant youth, is the diagnoses that we give to kids, they are not a label. That's not who they are. It's simply a way of talking about it. Everything's a spectrum. Sadness is a spectrum. Who's never been sad? So we've all, experienced some form of depression. Now, we can get into semantics about who has major depressive disorder, but I try to have that talk with the kids that I see even outside of this setting. Um, so they don't feel like, we're just sort of like labeling them and that they're a bad kid or something like that. Um, what about Doctors Fortuna or Adam?
I would like to say I want them to know that they are survivors and not victims. I want them to feel strong and they made it and there is support for them. So they are not alone.
yeah, and I would say, yes, to everything that, my colleagues are saying here. And also, there's different ways, and I'm actually teaching students about this tonight. There's different ways that we need to think about diagnoses, right? And we have different things in our toolbox, right? As clinicians, we have categorical things that are like the DSM-5, right? Where we're sort of saying, well, does the person meet the criteria? It's a little bit about like what I showed in my table, right? Like, do you have all the, the avoidance, the hypervigilant, all the things that we would imagine in PTSD and the impairment, right? Because we're always looking at impairment as part of our categorization. But then also we have to contextualize. And it's a little bit about like, what Dr. Adam was talking about, sort of what's the cultural context of those symptoms or those responses, so that we can understand, biopsychosocial model. And I was trying to assert, also sort of a policy environmental model that's included in there as well of how some people's responses might be adaptive, right? And I think that we can do that. We can say, okay, from a categorical perspective, the person's meeting criteria for PTSD, but what are the real adversities? Are we picking up that those are immigration stressors? How are those impacting on the child and family functioning? And how do we think about both the assets and the deficits that might be in the community that can mitigate, right? The sort of outcomes, the mental health outcomes of what the child's experiencing, so that we look at it in a much more holistic and contextual way than just, oh, here's a child with these categorical symptoms and counts.
Certainly agree. And then I'm just being mindful of time because we have about one more minute. So I think maybe what would be a helpful thing to end on would just be tips and tricks that you all have as far as navigating some of the moral injury that I think we are facing in these dark times, both as clinicians, but our patients. What are some of the things that we can kind of take away as we wrap up?
I think for moral injury, I think stick together. Look for those other people who would, like Dr. Sidhu was saying, are having that light, right? And I actually feel that when I do engage with community, and we work together, that gives me hope because I feel like every little thing I can do to make people feel and that I'm working with them, and that I'm respecting their dignity, that helps me have hope. And I have hope in the community, taking care of community as well.
Dr. Adam, any last words?
Yes, I would like to say that we all deal with very hard situation, and we can have compassion fatigue. And sometimes it can even lead to burnout, and we don't want that to happen. So it's important to have self-care. It is important to have self-awareness when this feeling is coming to you that you're upset about what's happening in the world and with your patient. What can you do to help yourself and soothe yourself? Also need to look at your balance of patient. Don't have all this patient with PTSD and war and all this struggle. Try to have some balance. And it's okay to seek help, get support from your colleagues. Look at your institute and what they are doing and how you can help them address this issue, because we don't want um, uh, people, psychiatrists, to give up. We want them to be there and help the patient in every way possible.
Yeah, I think one of my good friends once told me advocacy is the antidote to hopelessness, something like that. And
Hmm.
I think it's we all are faced with many things that are frustrating from, you know, for example, not being able to get a medication approved for a patient that we have, to all the systemic issues that we have, to really what feels like unprecedented and daunting kind of sorts of issues that we're facing now. Advocacy can take so many different forms. It can be that one patient that you just want to write that letter for. It could be um, coming to Advocacy Day for ACAP or the APA. It could be writing a little article, small, just a few paragraphs, for anybody. It could just any of these sort of small things that you do will help you feel like, like you're not feeling so hopeless about things. So, and we're always happy to have people reach out to us if you want to get involved in advocacy, but you just haven't really had a chance. Maybe you've been a busy trainee, maybe you've been really busy in your personal life, and as an attending who's all grown up, and you are just haven't really had the space, but now you're kind of feeling a pull to it. We're more than happy to help with that, and I can maybe see if I can put my email in the chat just in case people want to get involved.
Yes, that is perfect. And that kind of leads me to also let everyone know that a recording of today's session will be available. Also, the PowerPoint slides will also be available on our virtual forum website. Give us about a day or so, but we should be able to get it for you. And we are all just so happy and delighted to bring you this topic. We're going to take some of the feedback that you all said before, as far as new topics to bring you on child maltreatment. And I wish you a good evening and thank you so much for joining.